unmuted.
John, you can start.
Yes, we'll start shortly.
Okay.
Hello to everybody that's joining us today. We're going to we'll be starting in a minute or two to give some people a chance to join us. Hello to everybody joining us on the webinar today. It's John Muscaderi speaking. I'm the Scientific Director for TVN. This is our monthly webinar, these are held on the first day of on the first Wednesday of every month. And I will, at the end of this, I will show some upcoming webinars. I'd like to thank today our speakers and our panelists. And today's webinar is on the Choice Knowledge Synthesis project. And the speakers will be Dr. Paul Stoley, Jacoby Elliott, and Heather McNeil from the University of Waterloo. We'll introduce them first, and then we can talk about, and then I will give some instructions on how to submit questions during the webinar. So first of all, the leader on the project is Dr. Paul Stoley, who is the TVN principal investigator. This was a project, knowledge synthesis project funded by TVN. Dr. Stoley is associate professor and School of Public Health and Health Systems at the University of Waterloo, and cross appointment in the School of Optometry. He has a PhD in Health Studies from Waterloo, and an MSc in Clinical Epidemiology and Biostatistics from McMaster. He has over 30 years of experience in research in geriatric health services, including work in academic, governmental, and community centers, and he is CIHR funded for a variety of investigations that pertaining to older adults. And he is involved in research on how knowledge is translated into practice and policy, and how to meaningfully engage seniors in healthcare decision making and research, which is the major topic for today. Joining him for today's presentation and webinar are Jacoby Elliott, who's a PhD student under supervision of Dr. Stoley in Aging and Health and Wellbeing Program at the University of Waterloo, and Heather McNeil, who's also a PhD student, also under the supervision of Dr. Stoley. For the questions during the webinar, and to avoid interruptions, we ask that you submit your questions online during the webinar using the function there. If you type them in, and then they will be moderated at the end of the session. Please submit as many questions as you like. We'll get to them, to as many as possible at the end of the session. And if we don't get to them during the online portion of the webinar, we can always try to answer your questions offline after the webinar. These slides will be available on the TVN website in the next couple of days. But without further ado, I'd like to turn over the webinar then to Dr. Stoley and the other presenters. So thank you for joining us today.
Well, thank you very much, John. I'd like to thank TVN for the opportunity to present on our project today, and also thank TVN for the funding that we received to carry that project out. As a bit of background on this from our perspective, central focus of our research program over the last few years has been on how and what information gets used and shared in the care of older patients as they move across the healthcare system. And one thing that we have found through that work, which may come as a little surprise to many of you, is that older patients and their families are often not very involved in decisions around their care, even though they have a lot to contribute to those sorts of decisions. So we have responded to that in a couple of ways. One is that in our own work, we are trying to do a better job of engaging with older persons and family members in our own research program. And we've started a network to support that, and we'll be talking a little bit about that later. And also, when the call came out from TVN for a knowledge synthesis around patient engagement, we thought this is an excellent opportunity to see what we can synthesize from currently available knowledge and evidence about approaches that are meaningful and effective for engaging older persons, their family members, in decisions about their own care, in participating in research, and in participating in healthcare policy and other decisions. Now, had we known at the time how much work that was going to be, we possibly would not have taken this on. But once in, we carried through, and we were fortunate to have a very dedicated group of students here who were committed to the project, led by Jacoby Elliott and Heather McNeil. So I am going to turn the balance of the presentation over to them, and they will be taking you through the project. So thanks again for the invitation, and I'll turn it over to Jacoby and Heather.
Thanks, Paul. So thank you to everyone today for joining us. By the end of our presentation, you should be able to answer these questions. We will discuss the reasons why we conducted this review. We will explain why we chose a realist approach. You will have a better understanding on how to engage older adults in healthcare research, planning, and clinical decision-making. And lastly, we will talk about our next steps of this project. So for the rest of this presentation, Heather and I will be switching back and forth to present. So just take a moment now to think about what engagement means to you. It is important to recognize that there are currently many terms being used in this area. These include terms such as patient engagement, patient involvement, patient-centered care, client engagement, and even patient experience. We have chosen to use the term patient engagement for this project. You are also probably aware that there are many definitions used to discuss the idea of engagement. Early on in this project, we read a paper that discussed the lack of conceptual clarity as one of the greatest barriers to truly integrating patient involvement into health services, policy, and research. With that being said, we chose to use the Gallivan and colleagues definition that you can see on your slide, recognizing that the inclusion of family is especially important. So our research group had a CIHR-funded program of research called Info Rehab, where we followed hip fracture patients throughout their rehabilitation journey. We found that patients and families really wanted to be engaged, but healthcare providers were not including them in discussions around the care. This led to the development of the SHARP network, which stands for Seniors Helping as Research Partners. We created this network of older adults who we engage with through online and face-to-face discussions. To gather their feedback about our research, we learn about their experiences, or we share some of our research findings. Shortly after the development of SHARP, we had the opportunity to participate in a local event at a senior center where 200 older adults gathered for a forum called My Healthcare Forum Seniors in Control. We conducted mini group discussions with each table and learned that people really wanted to be engaged in decision making, but often didn't feel engaged as equal partners in their care. Many participants from this event showed interest in our SHARP network and are still working with us as research partners today. To date, we have over 60 members in the network, and we're always recruiting more people from our community. So engagement is a hot topic in healthcare right now. The importance of engagement is highlighted in the literature. However, there is limited focus on older adults, Canada's largest growing segment of the population and the biggest users of our healthcare system. This project aimed to address the limited focus on older adults by developing principles for their engagement in healthcare research and planning and healthcare decision-making. When thinking about healthcare research, the importance of engaging the community has been widely recognized and is shown here in this quote. The people who are most affected by research have a right to have a say in what and how research is undertaken. When thinking about healthcare decision-making, Cloutier and colleagues discuss the benefits of engaging patients and suggest that playing an active role in healthcare decision-making can improve patients' quality of care, efficiency, and health outcomes.
So, in response to this and the call from the TVN for a knowledge synthesis funding opportunity to support teams of researchers and knowledge users to produce knowledge synthesis that will contribute to the use of evidence in decision-making and practice for older adults, we needed to consider what the most appropriate type of review would be. Acknowledging both the current complexity of the healthcare system and the complexity of this topic with the interchangeable terminology and definitions that Jacoby just discussed, we needed an approach to understanding and engagement that would be applicable in real-world settings, something flexible and iterative. As many as you know, healthcare evidence is diverse. There are a variety of literature sources and types of evidence, and we wanted to be able to scope qualitative and quantitative, gray and peer reviews, as well as hear from key informants and voices not typically represented in the literature, specifically older adults. There is currently no consensus on the best approach to conduct a knowledge synthesis. Kastner and colleagues have proposed a scoping review to identify the most appropriate knowledge synthesis method, and the preliminary list included in their protocol paper describes 25 approaches. Of these, we believe that the realist synthesis approach developed by Pawson and Greenhill and their colleagues is most appropriate for this review. Realist synthesis is one of the approaches recognized and supported by CIHR's Knowledge Synthesis Funding Program. Realist syntheses address limitations of more traditional approaches to systematic reviews, which address effectiveness often narrowly defined, but do not address the why, for whom, and in what circumstances intervention or policy does or does not work. Realist inquiry is based on a realist philosophy of science that considers the interaction between context, mechanism, and outcome. It has been recognized as a policy-friendly approach to knowledge synthesis and is known for its iterative and flexible methodology. So for the Choice Knowledge Synthesis project, because realist review is an emerging methodology, the best practice standards are still under consideration. But we chose to follow those described by Wang and colleagues, which suggest 5 phases that are conducted in an iterative, overlapping manner. We will present them as separate stages, but please keep in mind that the methods were overlapping as new information emerged. These phases are clarify the scope, search for evidence, appraise and extract data, synthesize evidence, and disseminate, implement, and evaluate. We will now get into the details of what was done in each phase. In order to satisfy the realist synthesis goal of refining the review question and identifying a candidate series to populate, 4 subphases were conducted: initial consultations with stakeholders, a gray literature search, key informant interviews, and a workshop. We conducted 2 30-minute interviews over the phone with key informants which were audio recorded and then later transcribed. They provided support for our gray literature search strategy, for example, key websites to search and frameworks to look to, and highlighted the idea that engagement should be understood as context-specific. They pointed us to the spectrum of engagement as a popular framework for understanding engagement. We also consulted with our SHARP group, holding a focus group with 8 members who helped to confirm the importance of this research to older adults. They considered the project goals meaningful and provided depth to the terminology that we were using for our searches from the perspective of older adults. For example, sharing that involvement was a word that they understood better than engagement, and that they would prefer discussing person rather than patient. For the Gray literature search, we collaborated with our health science librarian here at Waterloo and did a snowball search on Google. Started off nationally and then moved to the UK as we learned that there was a lot of good work going on in this area there. Through this, we found a number of prominent theories and frameworks. After some group discussion about the findings of the Gray literature search, we brought the frameworks to our partners at Patients Canada and conducted an interactive one-day workshop with older adults and patient advocates. They again confirmed the importance of this work, with one participant telling us patients should be educating healthcare providers and other patients on issues in the healthcare system. They also talked about the idea of levels of involvement, with different opportunities to be engaged in healthcare research, planning, and decision-making, matching the needs and goals of older adults. They emphasized the importance of meaningful engagement opportunities for older adults. These participants highlighted 2 key frameworks from the list of all of those that we gave them: the NRC Picker 8 Dimensions of Patient-Centered Care pictured here, and the Vancouver Coastal Health Spectrum of Participation. This spectrum is related to the framework that was highlighted by our key informants earlier, but has evolved to be a circle, which was important to our participants. As they told us, I can understand this model, which is important. For a diagram to work, it should be intuitively comprehensible. These then emerged as the program series to be used throughout the rest of our review. The next step is searching for the evidence. Once the scope was clarified and we had our frameworks identified, we again collaborated with our health sciences librarian to create a search strategy for the peer-reviewed literature. Using the concepts and relevant keywords, we searched a number of databases. Papers dating back to the earliest coverage of individual databases up until January 2014 were included. We also included articles in both French and English. Papers were included if they reported description, assessment, or evaluation of strategies for engagement of adults 18 years and older. We paid close attention to articles focusing on older adults aged 65 and older. We excluded papers focusing on children. This is the flowchart outlining our search strategy. Once the duplicates were removed, the search retrieved over 15,000 articles. The papers underwent a title and abstract review. 10,467 articles were excluded, leaving just over 5,000 articles for full review. For the full text review, the articles were sorted into 4 categories: clinical, research, cognitive impairment, or we excluded articles after the full text review. For both the clinical and research categories, the articles were sorted into 2 groups: articles that focus on interventions and those focusing on theory. For articles relating to clinical decision-making, 208 articles were extracted and coded, and for articles that focus on research and planning, 120 articles were extracted and coded. We used a data abstraction table to pull out key information such as the focus of the paper, the type of evidence and methods, the results, setting, population, and we also identified whether there was a focus on older adults. We used the literature to populate our candidate theories, and within the data abstraction table, there were drop-down menus with both the 8 dimensions of patient-centered care and the spectrum of engagement domains. Using the information abstracted, we chose which domains best represented the article. We also recorded barriers and facilitators to engagement that were identified in the paper. We had frequent team meetings to discuss the relevance and rigor of the included articles. We had good inter-reviewer agreements. And as mentioned, our abstraction was guided by the theories suggested by our stakeholder partners. And as a group, we continuously reflected on how the literature was populating these theories. We just wanted to highlight a few things from the article. I'll have you focus on the middle row titled Engagement Spectrum.
If you think back to the slides that showed our candidate theory, you may recall that the levels went from inform, consult, involve, collaborate, and empower. So you can see for healthcare decision-making, 64% of the articles abstracted discussed involving patients. Only 11% looked at empowering patients in clinical decision-making. For research and planning, 66 of the articles focused on involving participants, and 20% focused on empowering participants. In terms of coding the data, we individually coded our data abstraction table using line-by-line emergent coding techniques. We met regularly as a group to discuss our themes. Once we felt as though we had reached saturation, we each coded 5 more articles. As you saw in the flowchart, 208 articles focusing on clinical decision-making were coded. This here provides a list of some of the codes. We had codes like location of care settings, communication breakdowns, wait times, trust, and power dynamics. Here is an example of the code list for research and planning. Keep in mind, we had an extensive list of codes, but we couldn't fit them all on the slide. You can see here codes such as role clarity, format of information being shared, size of the group, and privacy concerns.
So as each article was reviewed and reread, our themes and concepts were created and iteratively revised as we synthesized the evidence. We took information back to members of Patients Canada. We held a half-day workshop which helped us to both confirm and refine the components of our developing framework. For example, we found that the 8 dimensions of patient-centered care should no longer be used in our research planning framework that was in development. One participant captured this quite well by simply saying, "This just doesn't make any sense for research." Many other important themes from this workshop were identified, which included information sharing, relationship building, skill, knowledge, and experience. I'll just take a moment to let you read the quotes on the slide. So we took the input from our participants and continued on in our development of our framework. We returned to the data that we had extracted from the literature and began to reanalyze in our group meeting, mindful of the information that we had gathered from the previous phases of the project, especially the input from older adults. And so, although much of the literature did not focus specifically on older adults, our consultation process allowed us to represent the voices of these older adults, their friends, and family members. We are confident that the following frameworks are representative of their views on engagement because our methodology directed us to evaluate our results through member checking with our participants at multiple occasions in the project. They truly did have an opportunity to co-create this knowledge with us.
Now we'll look at our framework. First, we'll start with the framework for engaging older adults in clinical decision-making. We have developed this framework for engagement in healthcare decision-making, which includes key domains that emerge from the literature review, our consultations, and the workshop. Understanding the context, the patient, and the provider is very important and needs to be considered at all times. Communication and information exchange needs to occur among these levels to encourage meaningful engagement. Together, this will encourage the development of a relationship that needs to be built on trust and respect, and where roles and expectations are clarified together. A strong relationship is important for coordination of appropriate, effective, and efficient care delivery. So we'll just walk you through some of the principles that are associated with each component. So first and foremost, the patient must be a central consideration. Many articles and our expert participants discuss the importance of understanding the patient in terms of their characteristics and demographics. In order to gain a complete understanding of the patient, their social support network, such as a family, friend, or neighbor, must be acknowledged. We previously had used the term family caregiver, but after our literature review, we feel that social support network would be better. The patient's preferences, goals, needs, and expectations also need to be discussed. Attitudes and characteristics of healthcare providers were reported as playing a role in how and to what extent patients and their social support networks are engaged. Skills and knowledge of a healthcare provider are important, and the use of education and resources can help healthcare providers engage patients. It is also important to consider the context in which these strategies would be implemented. Literature suggests that a healthcare environment that provides comfortable space with a warm and welcoming atmosphere better supports patient engagement. Positive interactions between a supportive environment, healthcare providers, and patients and their social support networks create relationships needed for meaningful partnerships and engagement in decision-making. A strong relationship between providers and patients is built on trust and respect. Healthcare providers, patients, and their networks need to engage in open and honest conversations for the purposes of sharing information, educating each other, making decisions, and care planning. And lastly, care coordination. Engagement needs to be supported within and across the care setting through communication. Healthcare providers need to collaborate with each other to provide efficient and effective care. The use of different methods of documentation eases information sharing, which is needed for seamless care coordination across the system.
And here you will see a framework for engagement in research and planning. The key stakeholders involved in engagement in the research and planning, namely the system, participants, and investigators, need to be taken into consideration. For meaningful engagement of older adults to occur in the healthcare system, the interaction between these stakeholders needs to be within the context of a productive relationship. This interaction should impact the process and outcome of the engagement opportunity, whether it's in the research domain or in planning. Knowledge translation activities which arise from the engagement can further develop the relationship between stakeholders through continuity and education. The participant group should be composed of a diverse and representative sample of the population in question. Part of this diversity is in the different preferences that participants will have for engagement. Investigators need to create opportunities for these participants to be engaged in both research and decision-making at the level of their choice. Participant motivation, such as remuneration, is a consideration that shows the overlap between these framework components, as the system will provide constraints for this, such as funding and policy. System considerations occur in complex ways, including broad considerations that range from the physical environment and resources to policy. Community, government, and organizational support is integral for engagement. Both top-down and bottom-up approaches are needed. Investigators is the term that we chose throughout this project to discuss the researchers and decision makers involved in engaging older adults in research and planning. And similarly to the healthcare decision-making framework, the characteristics, skills, and experiences of those in these powerful positions influence engagement opportunities. As I mentioned, and similarly to the previous framework, the relationship is central to engagement in healthcare research and planning. Trust, role clarity, and communication are all essential components. Negative views and mistrust with healthcare and research are barriers to meaningful engagement for older adults. A culture of engagement needs to be encouraged in research institutions and in the healthcare planning sphere. Education of the stakeholders involved on the benefits of engagement could be a step towards this necessary cultural shift. Thinking about the process and the outcome, the research and planning method influences engagement opportunities. Flexibility, both in the methodology and stakeholder openness to change, are important. The timing of engagement opportunities needs to be considered. It should not just be a checkbox approach at the end of a project when submitting a paper or a policy report. Rather, it should be throughout and at the beginning of the project, built in. And finally, knowledge translation. We heard from older adults that disseminating research results encourages continued engagement. The format of information is very important. Finding out from your stakeholders the format that they would like the information presented in, having them involved in creating it, will encourage engagement. Continuity is important throughout the process of information exchange and will help to build lasting relationships, encouraging continued engagement. And here another example of the influence of the system, as investigators need to have the time to do this.
So here are some of our key findings. This realist synthesis has informed frameworks for engagement in healthcare research and planning and decision-making, and has identified a range of best practice guidelines and strategies for participants and patients, investigators and healthcare providers, and other stakeholders. Engagement is complex and should be viewed as a dynamic relationship. Strategies should be context-specific and need to be considered at a system level, patient participant level, and provider and investigator level.
Patients and participants should know that they have a right to engage in shared decision-making and in healthcare research and planning. Healthcare providers and investigators, as well as patients and participants, should outline the level of engagement that is appropriate for the situation, recognizing that the context needs to be considered. Communication is key to the development of open, honest, and trusting relationships. And in this relationship, it is important to continuously evaluate the level of engagement, as preferred levels are fluid and evolving and people gain knowledge, skills, and experiences. So as with any project, there are some limitations to mention. First, the type of review. Realist syntheses are an emerging method with few published examples. Those who conduct these reviews have stated that there is improvement to this method, as existing techniques to organize and synthesize the diverse information gathered from these reviews are not currently well operationalized. We were, however, guided by protocols out there and spent time as a group working through our methods before undertaking this project. Next, the perceivably unmanageable amount of literature. Our methodology, such as the implementation of random sampling of the articles for abstraction and the use of theoretical saturation, resolved this issue to provide a range of studies, creating a robust basis for the development of the presented frameworks and principles. Realist synthesis does not aim to review all the articles. As Fossman and colleagues suggest, the reviewers should not aim for an encyclopedic coverage of all relevant information, but for theoretical saturation. So stop searching at the point when no new information is added. Our team's experience with qualitative methods was quite useful in this process. Finally, we recognize that there are theories and frameworks which were not included in our review, unfortunately. Snowball searching on Google will provide you with a wealth of information, but it takes you in directions where you will miss some avenues of inquiry. The theories we used for this project, however, were guided by consultations with experts, key informants, patients, and their caregivers. We are confident that they are representative of older adults' preferences for engagement.
Now some of our next steps. So we have had the opportunity to take the frameworks and principles back to our SHARP group for feedback and further discussion. We have made some changes to our principles and strategies based on these conversations. We also created a lay summary of findings and distributed the report to Patient Canada members who participated in our workshop. We have submitted a paper for publication, and we have had the opportunity to present our findings at national and international conferences. Local knowledge translation initiatives include providing updates in our research group bulletin and social media pages.
So where to from here? We recognize that we need more feedback from healthcare providers and researchers. Our plan is to create toolkits of best practice guidelines for engagement to test in both clinical and research and planning settings. We also are planning to contribute further to the literature by publishing our findings from this project. You will see here a quote from a key informant about the importance of this work. And now, there are many people to thank and acknowledge on this project. The study was conducted in collaboration with members from the GHS group, as Paul mentioned at the beginning, and received funding from the TVN network. The older adults who were involved were so valuable to this project, from Patients Canada and the SHARP network, and we are deeply appreciative of their time and contribution to this work. Here you will see the collaborators on our team, including our older adult representatives. And so please feel free to continue to follow our work on Facebook and Twitter and engage with us on social media. Thank you.
Thank you. So that's the, thanks Heather and Jacoby for that presentation. So now I guess we're open to discussion, comments, questions from those on the line.
So I do have a few questions for you. There is a lot of evidence that patient engagement works, but we don't do it well. how do we get clinicians and researchers to increase engagement in the elderly?
Boy, there's $1 million question. I think there is possibly more interest and willingness among clinicians, care providers to engage meaningfully with their patients than perhaps sometimes we give them credit for. Now, often I think our healthcare system funding arrangements, organizational arrangements make it difficult for clinicians to take the time to involve a patient meaningfully. So one thing the work that we've done shows is that there's an opportunity to be flexible in the ways that can happen. We don't always need to have a process of engagement that perhaps engages patients in every aspect of decision making. In many cases, a patient might be quite happy to let the clinician take the lead on that in some sort of an emergency situation or another contact, and that's fine and that's reasonable. But over time, I think what our framework says is that it's important for providers to work to develop a relationship with their patients. It makes so that they can make decisions in a basis of common understanding of what their values and preferences are.
Further,
and I think I guess I would add we're hoping that this work might lead to some tools, resources, and strategies that might make it easier for people to demystify the process and find it easier to think about how to involve patients in decision making.
The next question that I have kind of relates to that, because it is how might your work be applied at the health system level? And I think you were saying that tools and stuff might need to be developed, but where would the starting place for health service planners be?
Yeah, so thank you. We do recognize that there is a place for some tools to be developed, and as a starting point for our health system planners is to just the recognition and the education piece on the importance of engagement is definitely a starting place. So getting out there, hopefully this work with the knowledge translation and the good work that TVN is doing to get this information out there on the importance of engagement and create buy-in from the system level, and then having opportunities to make space for engagement. And as we were mentioning, that this type of work takes more time than a lot of our typical and usual processes do, but that in the end the product is much more valuable to older adults. So creating the knowledge base on the value that engagement can provide is definitely a first step.
I think the health system recognizes the importance of engagement, but they've not always been in a position to do so in a way that allows a meaningful contribution from the public. So, having a suggestion box on the website, may not be a bad thing, but it doesn't go very far in establishing kind of an ongoing relationship of trust and common interest in terms of making decisions. So I think this work would point the system to finding ways to engage older adults, other patients, as members of the public, citizens, in an ongoing, meaningful way in a true partnership. So, less suggestion box, less, one-off consultations, more ongoing discussion and partnership.
So, Paul, how do you engage your SHARP network in using those, I guess, no tick boxes for them, but...
Thanks. Well, we do that in a variety of ways. We try to follow the principles that our work has identified and try to be flexible in the approaches that we take and understand the way in which those members want to be engaged. We have some online mechanisms communicating with some through email and social media. Others find it easier to get a text or to be called. And we try to bring senior representatives whenever possible into our processes, into our knowledge exchange activities. So, for example, we had a CAG symposium, we had a patient representative on our panel. We've involved them in our grant applications as collaborators, investigators, and as mentors for our students, in some cases informally and in some cases in terms of formal relationships. We've worked with them in person through discussion groups, individual interviews, and participation in our workshop. We've mentioned our newsletter is another way to engage. We always look for opportunities to get more people involved, and we're asking them for advice on how best to do that. I don't know if we've got this perfected yet, but it's something we've been committed to, and we'll continue to make a priority in our own work.
Okay. This is kind of a double question, is what did your older adult participants think of the research process? I guess because one of the other questions is asking that the era that you're looking at might be more a different model of care where they're more, I can't even use the word, they're used to not being involved in their care. Did that impact your process?
Well, I guess first we'll speak to the first part, which what did they think of the research process? And this was a really interesting experience for us, especially Jacoby and I as emerging researchers, highlight the importance of understanding the patient's past experiences, specifically in research. For example, with one of our workshops, when we went to start talking about engagement of older adults in research, it was very obvious that when we started our discussion, many of the older adult participants had what they would describe as negative experiences in the past, where they shared with us a variety of reasons, with tokenism being a really common theme, where they felt like they were just a box to check off. And it was important for us to keep an open mind and allow the participants to share these experiences and stories that were less than positive, because that provided a lot of really rich themes that emerged in the conversation around powerlessness and lack of information, and just a general lack of respect or value for the personal information that they brought to the research. So we tried to learn from this, and as a result, you can see that information in our work. From a more clinical side, I would agree that there are some members of that generation that would be in a more passive role in their care, but we, from the people who were involved in our research, and as we shared in the findings here, spoke to older adults who want to be more engaged in their decision making and want to take on more of a engaged role.
And I think what our framework would suggest is that if any person prefers to have limited involvement in their decision making, then that's their preference, and that should be respected. Just being aware that many people may be in that role because that's the only model that they've had. So at least providing the opportunities and the openings for greater participation, should that be their preference, or should they be interested in pursuing that. And then the way to get to that point, I think, is to have a strong relationship with the person, a strong relationship with the patient, a relationship of trust with participants in a research process, so that they know that if they are spending time and energy providing input, that will be taken seriously, that it will make a difference, and that they can see the results of that.
Okay. Here's another question. It says, beyond simple engagement with providers, What steps can older adults take to be involved in the policy and planning decisions?
Well, I think that's going to be something that's going to have to be looked at from the perspectives of all of those involved. I think that the healthcare system, the policymakers, the decision makers need to provide the opportunities for those meaningful sorts of engagements. They need to be willing to engage with and respect the input of the patients and citizens who are going to be affected by their decisions. And they need to be prepared to take the time to have meaningful opportunities, provide physical environments that are appropriate, and make sure that all the other logistical considerations are taken into account. You know, we may need to think about providing, you know, reimbursement for participants for transportation and for their time, and also for the research process. I mean, one of our participants commented, you know, when she gets involved in a research project, everybody else in the room is getting paid but her. And how does that make sense when you're bringing them in as hopefully an equal partner in the process? So I think the healthcare system needs to make those opportunities available. Research networks such as TVN can advocate for that kind of change, and I think that it's clear that TVN is doing so, is moving as making engagement of patients and citizens a priority. And then the word needs to get out to patients and citizens, and hopefully to encourage them to take advantages of those opportunities. But when they do so, those need to be real valuable opportunities so people don't get disillusioned with the process and realize that their commitment is going to make a difference.
Yeah, I guess the payment or non-payment will dictate who you get at the table sometimes. And one of the questions is, what type of background did your seniors have for this project?
So there was a variety of experiences and different education levels. One of the limitations of the sampling from SHARP, for example, is that they are what you might describe as not the most diverse group, because they do have an interest coming from experiences from the healthcare system, and positive and negative, that they want to share, but also many of them have high education levels and experiences in being involved in these types of activities. We are doing the best that we can to recruit and learn new recruitment methods for how to get people who aren't necessarily typically involved to try to diversify our representation.
So I think that's true. The SHARP members may not be fully representative, nor perhaps for the representatives from Patients Canada. So they, you know, the people who are willing to come to the table may be different than those who are unable to do so. I think another way that we try to address this, though, is in our own research. For example, in the work that we've done in the past around looking at care transitions of frail older patients, and the work that we're doing currently around care coordination in primary care, for example, to ensure that our data collection process includes interviews, consultations with patients and their families. So in many cases, those people are very frail, and we're still, we get an opportunity to hear those perspectives. So they may be involved in that case more classically as a research subject, if you will, rather than as a full participant in the process. But we're still making sure that we're trying to reflect their perspectives and engage with them as best we can.
Okay, here's the last question. Were there any challenges with using a realist synthesis approach?
Well, I think we could go on for that. I think there are. I think realist approaches make a lot of sense as a general framework. in the context of doing work around complex processes, complex systems. So the healthcare system is a complex system, engagement of patients and citizens is a complex process. So we weren't looking for, nor did we expect to find, any kind of linear mechanistic processes by which engagement should happen. So we didn't come up with that kind of a process. We came up with a really dynamic model. But I think that makes the realist synthesis approach appropriate, but it does make it challenging because there's no, it's not as regimented a procedure as, say, some other systematic review process. So, would it be possible that someone else might take on the idea of doing a realist synthesis, come to some different directions? I think possibly, and I encourage people to maybe take this on if they wish, because I think there's more than one way to look at this. But I think what we've done kind of gives a flavor of the richness and the complexity of processes and factors that need to be taken into account to support engagement.
Well, thank you for all the discussion, and I'd like to thank all the first of all the attendees for coming online. It's been a great webinar and a great discussion, and I'd like to thank our presenters for doing all the work on this and also presenting it today. As Paul said, this patient engagement will become an increasingly big focus of TVN, and particularly how do we actually increase the uptake of patient engagement over time and involve the frail elderly or the elderly in research, in the healthcare system, and in policy. And please stay tuned for this. We are going to be having a session for this at our annual general meeting. That's going to be at the end of September. In regards to today's webinar, there will be a brief feedback survey that will pop up on your screen after the webinar is finished. We value your feedback, and please let us know any opinions you have on the webinars. Also, we are interested in topics and suggestions for future webinars. Our webinar series is planned till the end of 2015, and we are currently planning for webinars starting in 2016, and any researcher or anybody who has an interest in the elderly is welcome to provide ideas for webinars, and we can explore them with you as to whether they would be a suitable topic to slot in on one of our webinar days. In regards to our next webinar, our next webinar is on, my slides won't advance. The next webinar is on June 3rd at 12 noon, and this is another TVN funded knowledge synthesis grant, and this was a scoping review to determine the current and future role of occupational therapy in the ICU, which is particularly relevant to elderly patients admitted to the intensive care unit. So please tune in for that one. Please follow us on Twitter. And finally, today's webinar slides will be available on our websites, as are the slides from all the previous webinars. If you have a chance, please review them. There are some interesting webinars, including this one. So just to close, thank you again for everybody for attending. Thank you for the presenters, and thanks to the staff for organizing this. And we'll speak to you on June 3rd. Bye then.